My name is Kareem Sadak, and I'm one of the pediatric oncologists and the director of our Childhood Cancer Survivor Program at the University of Minnesota at Health Fairview Masonic Children's Hospital. And it's been such a great day, so fun to see so many folks and learn such great information from everyone, which will continue with our breakouts this afternoon. And so today we have a phenomenal speaker, a colleague, a friend, Dr. Brad Miller. And Dr. Miller is a professor in pediatric endocrinology and has been a part of the university for a very long time. And now in his leadership role running our division of pediatric endocrinology, has been able to just create an incredible partner for all of us in the cancer world. Just a real great colleague to help us help our patients and families. And so he has done and taken care of patients and research related to so many topics, including the growth hormone and insulin-like growth factor related disorders, and not just within our children and survivors of childhood cancer, but also across other populations of patients, children with fetal alcohol exposure, patients from international adoptions, just really been an amazing asset and help for our patients and families. And without embarrassing him, he also has done a pretty good job on our March Madness college basketball bracket challenges and pool picks. He's a regular and he always pays up first or second. So we're grateful for that. But we just, of course, most of all are so happy to have him here. So give a big round of applause for Dr. Miller. Thank you.
Thanks, great.
It's all yours.
Absolutely. Thank you very much. Hello. We're going to put this guy over here for now, and we might need him later, but as long as my microphone works, I'm going to wander because the screens are in both directions, and I might want to point at them and maybe blind some people over there with the pointer. So my job today as a pediatric endocrinologist is to talk about hormones. And so I'll start a little bit at the beginning to say, I am a pediatric endocrinologist, one of my disclosures, not an oncologist. But as Kareem said, I share a clinic with him because we've recognized how important the hormones are as a complication of chemotherapy, radiation therapy, bone marrow transplant for treatment of cancer. But I also have to emphasize here, I'm a pediatric endocrinologist. So what I'll be talking about today is going to focus on childhood cancer survivors who become adults, but I'll try and point out the parallels that occur in adults who've had cancer and in areas where they overlap. And the treatments are going to be very similar. So my goals today are to describe the risk factors, the diagnosis, and the impact of the hormone deficiencies. And then how do we help deal with and beyond cancer? How do we help people do that? So I like to start out with Calvin and Hobbes because they're my favorite cartoon, and I'm just sad that they're not still producing more. But hormone deficiencies are when good glands go bad. So essentially, this is something that's acquired as a complication of treatment. And the challenge here is that our endocrine tissue is actually fast growing and replaced tissue over time, which is why it's so susceptible to chemotherapy and radiation therapy. And so the other thing I want to talk about here is what is a hormone. And I'm only going to talk about a few hormones today, but basically a hormone is a chemical that's produced in one part of your body and goes somewhere else in the body to do its job. And so I'll talk about the pituitary gland, which is the master gland, where it's sending out signals to the rest of the glands to tell them to do their jobs. I'll talk about the thyroid, which also does a lot of different things. And I'll talk about the gonads. Those are the main topics that I'll target today, just in the time that we have. And then at the end, open it up for questions. Specifically, I tried to leave a lot of time for questions because you're not all cancer survivors, and also you're not all childhood cancer survivors, which is going to be a bit of my focus. So who knew that pituo actually means to spit? or pituita in Latin was mucus. And so I have a baby there because that's all they do is spit. But essentially the pituitary lives directly above your palate. And so people actually thought it was a mucus secreting gland. They didn't realize that it wasn't making hormones and sending the rest of the body. They thought it made spit. So it doesn't. um, I use this slide in cartoon to just show what we think of as endocrinologists as the feedback loops. I'm not an engineer or an electrician, but these things really make sense to me, which is why I became an endocrinologist. So there's two different cartoons showing it in a different way, but the hypothalamus is the base of the brain, connected to the pituitary gland through blood vessels and a stalk that comes down directly connected to send the signals from the hypothalamus. So your brain taking all the signals from your environment. This is a complicated slide, and I probably should have put the computer up here so I could read it. But basically, this is from a paper that talks about the recommendations for how do we decide somebody is at risk for a hormone problem and which ones should we screen for. And as I mentioned, there are certain chemotherapies that are more toxic to different systems. And so hypothalamic pituitary dysfunction is what this slide focuses on. And so it's really saying, do I have a problem coming directly from the brain versus do I have damage of the thyroid itself or the testicle or the ovaries itself? And so in brain tumors, children are treated and adults are treated with radiation for some of those tumors. And unfortunately, the hypothalamus and the pituitary gland are in the radiation field. And so you damage the ability to send out those signals. If you had total body radiation for a bone marrow transplant, you still got radiation, but that risk is lower. So there is still a potential problem. And then I'm suddenly humming, so I apologize for that. I can sing, but you don't want me to. And then also on this slide is talking about the timing. When do we need to start looking for some of these issues? And interestingly, some of these happen right away after a treatment occurs. So there's damage from the chemotherapy or the radiation right away, but more of them happen later. And so they're sort of insidious. We think everything's okay, and then suddenly we start to identify symptoms and those problems. Some of these endocrine issues happen because the tumor actually lives next to your pituitary or hypothalamus. So it's already in the neighborhood and it's knocked out those functions from the very beginning. We talk about the modality of screening. How do we look? And this is where I think long-term cancer survivor follow-up is so crucial. But it also happens with your oncologist if you're still following them. And it can happen with your primary care physician or provider, because these guidelines exist. They're on the website. You can go and find, how often should I have this tested based upon my experience with my cancer? And many programs, including the long-term follow-up program, they give you that passport that says, this is what I had. It's really crucial for us to know, did you get radiation? And if you did, where was it? And what kinds of chemo did you get? And where did they put it? Is it in the spine? Was it through an IV? Did you take it by mouth? Those are all important things that we use to help decide the risk. Some of what we're doing is the physical exam. There are features that we're looking for on the exam to say, you're more likely to have a problem because your thyroid is bigger than it should be, or it's smaller than it should be. Your weight can be affected. Your growth, if you're a kid, can be affected. All those things that we're using to incorporate into the diagnosis. And then I said hormones go from one part of the body to another. They go through the blood. So some of my patients call me a vampire. I'm not, but my lab technician is. And I'm the one who does ask them to take it. So I feel badly because endocrine, we always need blood. And so it's a challenge of, fortunately, when people are, still have a port or that sort of access, that's easy. But in the long-term cancer survivor part, that's more hard. And then we talked about when should we refer? to an endocrinologist. So I'm part of our cancer program right from the beginning. I see some of the patients, mostly in the brain tumor population, shortly after they're diagnosed to help say, do they already have endocrine problems because of where their tumor was? And so the timing is going to be really crucial that we're involved. But many times your oncologist or your primary care provider is going to include an endocrinologist only when they're needed. So if there's not an endocrine problem, just like usual, we're going to screen for them with our different tests and then decide, do you need to see the specialist? I wanted to just emphasize the number of different things that happen in terms of endocrine complications and the variety, how many people are impacted. And I think that was actually back on, nope, it's on the next slide. So 40% roughly of childhood cancer survivors with brain tumors have growth hormone deficiency, followed by 6, 10, and 3% of other hormone deficiencies related to the tumor, the radiation, and the chemotherapy. This is specifically brain tumors. If you have a germ cell tumor, unfortunately, the germ cell tumors like to live right next to the hypothalamus and the pituitary gland. So that number is even higher all across the board because of its location. And again, it requires radiation. So I just wanted to emphasize those to say location and what was the treatment are increasing the risks. It can happen a long time later. And so in this slide, this is years. For hormone deficiencies involving the gonads, it could be 8 to 10 years later before this shows up. And what I like to tell people is that our hormones decline with age naturally. And if we had damage to the hormone producing process early, we moved our 100% down to 80%. And our body is doing its best with that 80%, but that 80% is going to fall over time just naturally. And at some point, you're going to hit a threshold where that 80% is now 30% or 10%, and you're going to have symptoms that are related. And so that's part of that latency, is that naturally the hormone function changes with age. And so it's still important to keep looking even as we get older. This was the slide that I was thinking about earlier. Is it actually says that endocrine and metabolic complications of childhood cancer survivors exceeds 50% in patients who survive into adulthood. And so that's the challenge. And it's because our chemo and our radiation have been so successful. And this is one of the targets that, as Dr. Blaze was talking earlier, we're improving our therapies. These are going down because they've been recognized as an important long-term complication of treatment. So why do we worry about endocrine complications? I mentioned growth hormone deficiency, pancreatic beta cell dysfunction. That's a concern because if you damage the pancreas, and we worry about diabetes because it's such a prevalent problem for our health. If we damage the pancreas with chemo or radiation, then type 2 diabetes is more likely to happen. There seems to be something about chemotherapy and or radiation therapy that increases your risk of long-term type 2 diabetes, your long-term risk of type 2 diabetes all by itself. So I tell all of my cancer survivors that whatever your family risk was for heart disease, you've just now upped it by having had cancer and chemotherapy. And so we have to work harder to make sure you're healthier. Your lifestyle choices are healthier. If you have a family history of cholesterol problems, we address them earlier. And so those are things that we really have to pay attention to. Hypogonadism, we'll talk about, that's the not making the sex hormones like our body needs. Hypothyroidism, and then altered body composition that can be hormonal, but it can also be related to the chemotherapy. And the issue with that is that when we think about where fat is, and I got plenty to demonstrate if anybody wants to see, the fat that's out here is not as high risk for heart disease in the long term. It's really the fat on the internal organs. And so Cancer and hormone deficiencies promote fat accumulation in those locations that are the worst for your long-term heart health. And so we have to make sure that if there is a hormonal abnormality that's promoting that, that we identify it, and if it's safe and appropriate, that we treat it and replace it. And as an endocrinologist, I feel good that we have treatments for most of these hormone deficiencies that we can give. And I'll talk a little bit about that. I'm going to talk a little bit about growth hormone, but it's just a small population of people who have growth hormone deficiency. It's what I do. It's my meat and potatoes. And so that's part of why I focus on it, but also because it's an unrecognized complication of chemotherapy and radiation therapy in a lot of circumstances. And unfortunately, if you're growth hormone deficient, it does just what we talked about before. It lets you accumulate the fat in the places that you don't want it. And it also has long-term complications in terms of your bones, your muscle mass, and your long-term quality of life. So again, we talked about the growth hormone up here, the signal coming from the hypothalamus down to the pituitary. It affects liver function, bone health, muscle tissue, kidney, fat mass. So it's working through all sorts of different systems. And everybody else thought growth hormone just stopped when you got as tall as you were going to be. But it's really a metabolic hormone. So they probably should change its name to something that really explains what it does. But it really is keeping your muscle and your bone health up. It's one of the hormones that when we have exercised, helps us actually repair the muscles after the exercise and repair the little microfractures in our bones because we've been running too much. So it's an important hormone for us to keep on the list. As I mentioned, it regulates glucose. I didn't mention glucose. It regulates fat metabolism, but it also regulates our glucose metabolism. And so it's an important hormone in that aspect as well. And this slide shows more the specific areas. I talked about the adiposity, et cetera, and emphasizes the pieces that can improve with growth hormone replacement therapy in those who are deficient. I want to emphasize that growth hormone isn't going to take somebody's fatigue and make it better from cancer chemotherapy, because fatigue is a huge issue, and I don't want to, misspeak and say growth hormone is the cure for everyone's fatigue, or thyroid hormone, or testosterone. But what we've recognized over time is that it's one of the components that, if it's not replaced, can worsen your fatigue, can worsen your weight gain, can worsen your body composition changes that happen with cancer and cancer therapy. This is from the Minnesota Childhood Cancer Survivors Study that basically says that people who have growth hormone deficiency had more increased risk of cardiovascular disease in the long term. They used siblings and cancer survivors and showed how different the children who'd been through cancer were in their metabolic disease, and that growth hormone was a component of that. And when we think of metabolic disease, it's that pre-diabetes state of I'm insulin resistant, so my pancreas has to work harder to do the same job to keep my blood sugar normal. And over time, that leads to the failure of the pancreas in making insulin and ultimately type 2 diabetes. So the impact of growth hormone replacement, it improves the multiple cardiovascular risk factors by decreasing the total and the abdominal fat mass. It actually also improves endothelial function. So we think of endothelial function as basically what's happening when cholesterol and fat are being deposited in the blood vessels that are leading to the coronary or increased risk of stroke. So those are the things that we want to think about. We increase the muscle mass, which makes us more insulin sensitive, because more muscle helps the blood sugars stay normal. We decrease inflammation because fat increases inflammation in our body in general, and definitely when it's in our blood vessels. The challenge is when we think about growth hormone deficiency, we don't have enough numbers of either kids or adults with growth hormone deficiency to prove that giving growth hormone treatment to those patients will actually prevent heart attacks or strokes, because you need thousands and thousands of people to do that. And so we know that it changes all of the markers that increase your risk, but we don't have enough numbers of people to say it definitely prevents those things from happening. So does treatment of growth hormone deficiency improve outcomes? I mentioned there's evidence that it improves the long-term outcomes. It's still lacking because we don't have the numbers. But importantly, when people hear growth hormone, they think it's going to make cancer grow too. And that's one of the things that I work with pediatric patients who aren't growing well and need to really emphasize that growth hormone makes everything grow. So we don't want to use it when the cancer is still there. But once the cancer is gone, this does not show any increased risk of making the cancer come back. And so I just want to emphasize that it wasn't an issue for them to receive it once the cancer was treated. And the other thing is that in the long term, growth hormone treated adults, mortality wasn't any different from the untreated population. So we weren't seeing deaths because they received growth hormone therapy more than they should. And the risk of getting cancer in adults who were treated was not different from the general population. So I think those are just important things to emphasize on the growth hormone side of things. So hypothyroidism is actually the most common endocrine complication that we see, and it's because hypothyroidism is already common in the general population, and the thyroid is very sensitive to chemotherapy and radiation, and unfortunately it's in the field for many radiation treatments. And as I mentioned earlier, fatigue is one of those challenging symptoms that it's going to show up in a lot of the endocrine hormone deficiency categories. Weight gain, I think that happens in a lot of people too, whether they're trying to gain weight or not. Cold intolerance, I heard about chemotherapy related cold intolerance or changes in temperature tolerance, so that's a challenging one. Constipation, dry skin, hair loss, difficulty concentrating, menstrual irregularity. The guys don't have that last one, but all of these things are so pervasive in cancer survivors that it's really hard to say, do I have hypothyroidism or am I just tired, old, and fat? That might be me. But that's where the screening comes in. We really have to be consistently looking at the thyroid function in our patients, whether who've been cancer survivors. And so that's where the guidelines, come in to say, how often should I look? And if there are symptoms, are there different tests that I need to add into the mix? So primary hypothyroidism is just when the thyroid itself doesn't work. And so as I mentioned in that feedback loop, the brain says, I'm not seeing enough thyroid hormone come back from the thyroid. So I'm gonna beat him a little harder by sending more TSH down. So for me, when I see an elevated TSH and a lower or low normal signal from the thyroid, I know the thyroid's not working 100%, and the patient could benefit from getting thyroid medicine, thyroid hormone replacement. Central hypothyroidism is when that signal from the brain no longer can be made, and it's harder for us to diagnose because we're used to using the TSH to help tell us when the thyroid isn't working. And so your T4 might be 1.2 before you had cancer, and that's kind of where it lived, and now it's hanging out at 0.8. That's still normal, but it's half of what it used, or significantly reduced compared to what you used to have. That's really hard for us to diagnose. We don't have the magical tool there. But interestingly, when we give thyroid hormone in those circumstances, sometimes even if we get it back to 1.2, we don't necessarily see a benefit. So it's a challenge with central hypothyroidism to say, when do we treat and when do we not? If over time that hormone keeps falling, and that's a theme also with testosterone or estrogen. If your hormones are going down over time, it also is a signal for us to say you're not making as much as you should, and we should be thinking about treatment. So the cardiovascular impact of hypothyroidism, if you have hypothyroid, you tend to gain weight and you tend to worsen your cholesterol problems. So your lipids are more likely to be abnormal. Treatment is actually fairly simple if you remember to take your pills. It's a once a day medicine. One of the challenges with thyroid hormone is that you need to take it on an empty stomach. So it's always the balance of, when do I take my medicine? I forgot to take my medicine. Can I take it now or not? So those are practical challenges of taking the medicine. Benefits of treatment, we have the improved adult height in children. So thyroid hormone actually helps you grow also. Metabolic health and bone health. Actually, if you have a hypothyroidism, you're more likely to have osteoporosis as you get older, because it's also helping the bones gather in the calcium and make those bones stronger. There are risks of treatment. As we get older, there's a finer window between my normal thyroid hormone level and my just a little bit high thyroid level may tweak my heart rhythm and send me into an arrhythmia. And so that's a significant concern, but it just means probably that we have to do more blood testing to keep track of it. Here's that same hypothalamic pituitary gonadal axis that I talked about earlier. And I just wanted to use this as the transition slide to actually talking about the damage to the testes and ovaries. And because this is such an impact on families and patients long-term in terms of sexual function, heart health, bone health, and fertility questions, I chose to focus in here. And this is, again, cartoon on the left side of the slide that's just showing that feedback loop of the different signals coming back. And on the right-hand side is showing how those hormones change during the process of a menstrual cycle. And so you can see that it's a very fine-tuned dance of hormone production that the ovary needs to see to regulate the process of going from an egg to a follicle to ovulation to a fertilized egg, if that's what's going to happen in the process, and also to shedding the lining related to the menstrual period. And so you can see that if that ends up being affected by either radiation or chemotherapy, that you can easily see that fine-tuned dance is not going to happen, and irregular menstrual periods are going to happen. But it also tells us a little bit about how do we need to give back hormones if we're going to replace them. And so in the middle panel, we see the estrogen being at sort of a steady value and then jumping and then going down, and the progesterone coming up later. And so that's when we look at the oral contraceptive mixed pills of like, here we're getting this hormone there, and there we're getting that much hormone there. That's what those are trying to balance. And it doesn't always work. So when we are replacing hormones, we can see challenges of women having either no period or heavy periods or spotting, depending upon the combination that we have used, and sometimes just trying to find the best combination for their residual hormone production, if there is any, and the balance for how their body needs. That's what we're trying to do with, sadly, a little bit of trial and error. So the risk factors include chemotherapy and the alkylating agents. There's a group of medicines that are really, really nasty to the testicle and the ovary. And the parts of the testicle and ovary that are the most sensitive are the germ cells, the eggs and the sperm. And so those are the most likely to be damaged. Depending upon the age of the individual when they're treated, there's also an increased risk or decreased risk of damaging the testicles and the ovaries. So very, very young children may actually not have damage because they're so young that the ovaries and testicles are sleeping. They're not doing anything right now, so they're not dividing rapidly. There have been some treatments that have tried to protect the ovaries in these circumstances, or the testicles, whether that's physically taking out a piece and storing it away for later, or it's giving a chemotherapy, I say chemotherapy, a hormone therapy that will actually tell them to be quiet for a little while. So Lupron is one of the things that people use to suppress the menstrual period during chemotherapy, but at the same time, actually turn the activity of the ovary down so that potentially the ovary will survive the chemotherapy more easily. So I mentioned fatigue. If anybody has fatigue, yep. So that's again, it shows up on every one of the slides for the hormone deficiencies because they're involved in so many different processes. Lack of stamina, difficulty building and maintaining muscle mass, irregular menses in women, amenorrhea, decreased libido, sexual dysfunction in both men and women, and gynecomastia in men. So low testosterone in men, you end up having a higher level of estrogen for testosterone, and so you're more likely to build breast tissue. And the imbalance of gaining more weight also doesn't help. Primary hypogonadism, we said before, that's when the actual testicle or ovary is damaged, and so the brain is sending higher signals. It's exactly the same as what we see during natural menopause. And so people, for women, we will sometimes call this early menopause or premature ovarian failure. And we treat it the same way, except in younger women, estrogen replacement therapy is unlikely to change your future risk of cancer, for breast cancer or other things, because we're just replacing what the body would have naturally been making during those windows. And so it's still a balance when you're talking about it to say, is there a risk of breast cancer in this family because of their already known risk? Do we change how we approach it or not? And so we have to make some decisions in those categories of, is this person at risk if we give them estrogen? Do we just use progesterone for that process? And what are the risks and benefits of that? One of the challenges when we look at boys that are going through puberty after cancer therapy is that a big part of the testicle size is actually the sperm machinery. And so if you've damaged them early, they don't get big like they normally would through puberty. And so it's one of the signs we use to say, is he in puberty or not? And we're missing that sign. And so we have to rely more on other signs like pubic hair and the hormones in the blood. And then we can also use breast atrophy. If your body isn't making estrogen consistently over time, in a younger woman, we can see the breast tissue atrophy sooner than we would have expected it to because of that hormone deficiency. I mentioned the cardiovascular impact of hypothyroidism. It's the same direction for hypogonadism, impacts weight and lipid abnormalities. Treatments for hypogonadism are primarily estrogen for women in an oral form or a transdermal patch. For testosterone, there are intramuscular, subcutaneous, topical, and there are some oral versions, although they cost more than my Prius, I think, per year. So they're really expensive, but it'd be nice not to have to do a shot as frequently. So the benefits, we want to support normal pubertal development in kids that are treated and then maintain the appropriate secondary sexual characteristics. But long-term, we're talking about bone mineral density, psychological well-being, including sexual health and quality of life. The risks of treatments are the increased risk of blood clots. And so if you make estrogen or you make testosterone on your own, your body has a fine balance of saying, I've got enough, I don't need more. But if we're giving it to you, we increase your risk of blood clots with both testosterone and estrogen, much more estrogen than testosterone. And then there's always the ongoing discussion of the risk of breast cancer risk when we're giving estrogen in postmenopausal women. These come from a recent guideline where we talk about the surveillance modality that should be used at different ages. And essentially, this is a guideline to the providers to say, what are the best tools? And I show this group of slides to again say, these data are out there. There are cancer survivor websites where you can see the recommendations that your providers have access to. If they don't know them, you can give them to them. I have a lot of patients who bring guidelines like this to me, and I'm like, thank you very much. I wouldn't have known that. And if you hadn't given it to me today, I would have had to look it up myself because I don't use them every day. So I wanted to focus on this one because anti-Müllerian hormone gets talked a lot about for women related to fertility. When I showed the slide of the ovary and the egg going from egg stage to follicle stage to ovulation, the anti-Müllerian hormone is relevant in that process. So it doesn't start being expressed until the egg starts to move into the different follicle stages. So people use it as a marker of ovarian reserve to say, what's my likelihood of being able to have children after my cancer therapy? And like all of our tests, it's not perfect, but it's a marker that says how many of those eggs are still there and how many eggs are in that early stage of going from egg to mature follicle. And so we'd love to have a better marker of egg before they change at all, because that would be better than this, which requires a little bit of maturity to actually be there. So again, if you're interested in fertility after cancer therapy, this is one of the numbers that people might look at, but it's only a piece of the puzzle. And so seeing a reproductive endocrinologist or fertility specialist to help integrate that information and say, what is my potential for pregnancy on my own or through assisted fertility techniques. We talk about pre and peripubertal survivors here, that we really need to see kids early to help understand what's going on with them, and do we need to intervene? And then post-pubertal, we want to look at if they've received gonadotoxic therapy or radiotherapy impacting the ovaries, if they're having menstrual dysfunction, and in men, if they're having erectile function difficulties. Those are things for us to make sure and refer for. And then if you actually find a problem as the endocrinologist or the primary care provider, knowing what to do about it. I mentioned sex steroid replacement therapy, and for future fertility, again, recommended that if they've had chemotherapy or ovarian radiation, even if there aren't signs of failure, that meeting with a reproductive endocrinologist early or fertility specialist early, your eggs naturally decrease over time anyway. And so if there's been another hit to them that could accelerate that, you may run out of time faster. And so thinking of it early in the process is really important. This is the list of different things that can cause hypogonadism and infertility. So I mentioned the alkylating agents, radiation therapy directly to the gonads, bone marrow transplant, radiation to the brain that's sending the signals, as we mentioned. And then if there's been a testicle or ovary removed, you've got reduced potential. And then cisplatin seems to have a bigger impact on fertility in boys and men. And then for females, we talked a little bit about the timing. I'm a growth and puberty guy, so that's why that's there. The clinical history and physical exam are really important. And as I mentioned, the FSH and estradiol. And it's actually recommended that AMH not be the primary surveillance modality for fertility, as I mentioned, because it's just not a perfect screen or assessment there. And then counseling for fertility options should be offered to all at-risk adolescent and young adult cancer survivors. There are some new technologies of oocyte or embryo cryopreservation, testicular tissue, and ovarian tissue. But the recommendation, because the ovary tissue is still early, it's not yet standard practice. I think it will be soon. Sorry, I think I just blinded somebody over there. And then for boys, we're looking at the same growth and pubertal development and looking for hormone deficiencies, but also early on doing semen analysis to investigate. But there are also, in addition to endocrine problems, you can also have sexual dysfunction because of radiotherapy that's exposed that area, and any surgery to the spinal cord or sympathetic nerves of the pelvis or in the pelvis. So I mentioned for women the same counseling for fertility options. And again, there's a moderate recommendation for harvesting testicular tissue for cryopreservations. That's moving more towards a strong recommendation. And then the last group that I wanted to talk about before I wrap up is endocrine complications following a bone marrow transplant. So before I talk just about the damage of the chemo and the damage of the radiation, if you get a bone marrow transplant that is not from your own cells, so some people I got super high dose chemo and then I get my own cells back, that's different. If you actually had to receive cells from a donor, you're at the risk of developing, autoimmune disease from the new cells coming in and not recognizing your thyroid is your thyroid and not the person who you got the marrow from. And so autoimmune thyroid disease, either underactive or overactive. So both can happen. You can get autoimmune diabetes, the type we typically think of happening in kids, Addison's disease or adrenal insufficiency, hypophysitis, inflammation of the pituitary and hypothalamus related that can cause the hormone deficiencies. And I didn't talk about some of the newer therapies that are causing some of these autoimmune type problems. So some of our new checkpoint inhibitors or antibody therapies that are being very successful in treating cancers are starting to have some of these autoimmune type of impact on the endocrine system, but they would be screened for in the same way. It's just making sure we know that connection. You had this treatment, we need to watch for that as a potential outcome. So to summarize, endocrine complications of cancer therapy affect most cancer survivors, whether they were children or adults. We're going to see an impact on the body, and they increase the long-term risk of metabolic cardiovascular risk factors. So they're part of why we're at a long-term increased risk. We know that replacing those hormones reduces the risk and improves quality of life. I mentioned hypothyroidism is common and can have long-term impact on bone and heart health. Growth hormone deficiency has an impact on significant body composition changes, and that can lead to increased insulin resistance, that increase the risk of metabolic syndrome and cardiovascular disease. And then hypogonadism leads to significant body composition changes, which increase the risk of metabolic syndrome and cardiovascular disease. Sexual dysfunction occurs due to hormone abnormalities, as well as other complications of cancer therapy. And then lastly, infertility is a really heartbreaking complication of cancer and its therapies. And there are some new techniques that are coming that could be provided to people that are receiving treatment now. But really talking with that reproductive specialist to say, if I'm interested in having kids, what are the things that I need to think about? Are there risks because of the cancer that I had, risks because of I'm not going to be able to have my own sperm or eggs that we can use, or other options that we have. So I'll stop there and open it up for questions, and happy to talk about adult-related endocrine complications, but just with the caveat that I am a pediatrician. Emily. I've asked them to turn off your mic so you can't ask any questions.
Hello. Oh, there we go. I think this is a question you were anticipating, but this is an online question. Will you speak about long-term estrogen suppression used with most breast cancer patients, AI inhibitors, etc., and what hormone deficiency problems to watch for with that? How are they treated?
Yeah, so that is a tough one, and not being an adult endocrinologist or an adult care provider, what I'll be telling you is probably not the most latest data, et cetera. But aromatase inhibitors and other things to suppress estrogen are going to have a long-term impact on bone health, because bones are really sensitive to estrogen in both men and women. And so in that setting, we want to make sure that we're doing all the things to make our bones strong. And so that's dietary. We know calcium and vitamin D are crucial to our bone health. It's exercise. Weight-bearing exercise is really important for our long-term bone health. It may be other therapies that your provider prescribes to say, we need to give you a medicine to strengthen your bones because you're at that risk. There are other estrogen-like medicines, or some that block estrogen activity, but at the same time allow some additional estrogen impact on the bone, or estrogen-like impact on the bone, that are more in the adult arena, that may be part of that bone health category. From a nutritional perspective, there are a lot of things that people look at as supplements and natural replacements. And again, in the pediatric world, we don't see them used and don't see much benefit from them. But the reason there's an integrative health conference or session in parallel here is there's a lot that we in the medical Western medicine don't know, that I think we just have to be really cautious of making sure what we're doing is safe and not going to cause any problems to either our body or our pocketbook unnecessarily.
Thanks, Dr. Miller. That was terrific, and just a lot of great information and a lot to think about, and a lot to go back to our oncologists, providers, primary care physicians, nurses, providers, and just thanks again for all the time. One more round of applause for Dr. Miller.